All right. So a lot of times, paroxysmal hypertension. There's one cause of if it is truly paroxysmal, truly blood pressure goes up and comes down. Truly, and you are sure, not on medications. There's something we check for, and that is pheochromocytoma. We check if there is a tumor that is secreting occasionally catecholamines, makes it to go up suddenly. But that is hardly the case. What normally happens is that that patient may not be intensive. They came to the hospital, they are afraid, their blood pressure went up slightly, we gave them drugs. When they went home and their blood pressure was not high, it was normal, those drugs became too much for them, it slammed back down. So that's likely what happened. And those ones that have diastolic, that is say diastolic, the drug doesn't need to be changed. They need to be somebody and adjust the drugs and to come down. So more often than not. So what of the two that we normally use, ambulatory blood pressure, like Sharon showed us, we put a swig on the person goes home. Typically, they've been off drugs for a while. 24 hours, it will be measuring the blood pressure every 15 minutes during the day and every 30 minutes at night. And then we will see a full array of the blood pressure in the person's habitat. And then we can now decide truly they have high blood pressure or they don't. So normally that is what is the case. So we'll start ACLS now. More questions? Okay. So we'll stop now. Okay, so let's go to advanced cardiac life support. We'll try and do this fast. Please, I need your full attention. Full attention. Biro, paper, out. You will not know it. The next time you will have it, it will be with a patient. And I tell you at that time, I make mistakes. I have to go back and review it again and again and again. So please and please, you want your paper out. You want to be able to do it. You want every member of your team to have it in their head so that they can remind you, Chief, what about amiodarone? Chief, we have not given lidocaine. What about this? What about that? You understand? So we can now rub minds. So everybody needs to know what is involved. So ACLS simply means a standardized algorithmic set of tools or treatments used to treat life-threatening cardiovascular conditions. Just some standardized ways of if this happens, do this. If this happens, do this. The truth about the ACLS is that there are so many algorithms, this and this, this and that you need to read it over and over again and master it so that you can be able to think on your feet and be able to answer all the questions as they come. So, 1, clinical guidelines. 2, for urgent and emergent treatment. 3, for life-threatening cardiovascular conditions. Number 4, those ones that will cause cardiac arrest or have already caused a cardiac arrest. If you don't treat it, it's going to cause a cardiac arrest or it has already caused a cardiac arrest. And number 5, we use advanced medical procedures, medications, and techniques. More often than not, ACLS typically requires a doctor in the room or specialists at times, but sometimes if you've done it well enough, long enough, practice enough, you could do it on your own without a doctor in the room if you have everything available. ACLS also almost always requires a team. You cannot really do ACLS and say you're the only nurse in the duty, so let us just do. No, it's unlikely that you'll be able to be successful. It needs a team. This is something that cannot be done typically by one person. You need no less than 6, 7 people to do successful ACLS. So when we have a code in the hospital, what happens is that we have almost 8, 9, 10 people in the room doing the thing. Different people with their different jobs, and I'll explain what that entails to you. So, there are 8 steps as defined by CardioCare for Nigeria of ACLS. Number 1, and I believe is the most important, preparation. Preparation. Number 2, BLS, which we did yesterday, which you should remind yourself. Number 3 is assessment, primary and secondary assessment. Number 4, crisis resource management. Number 5 is where that ECG we learned. You must use it then. If you don't have a monitor to see the ECG, you are not doing ACLS. You are praying, you know. So you are supposed to be pouring anointing oil. Same thing. Okay? Then airway management and ventilation, post-cardiac arrest care, and specialized interventions. I will talk about a few of them. So number 1, that's preparation. Are you prepared for ACLS? What does it mean to be prepared for ACLS? So number 1, you need trained personnel. People that know what ACLS is about, know those algorithms. You need to have even people that can do advanced airway. Sometimes you could be trained in ACLS, but you may not be trained in putting an advanced airway. In that case, did we get the laryngeal mask? Mr. Victor, okay? In that case, sometimes you can just use laryngeal air mask, the one that you can just slide it in, it just holds the place in. It works like an endotracheal tube in the interim. Okay, I hope we could get one to take across. Number 2, preparation, monitors. You cannot do ACLS without monitors. If your hospital does not have monitors, please, you are not doing ACLS. And you are unlikely to be successful. You are unlikely to be successful. If you are doing surgeries without monitors, you are taking a very big risk. Very, very big risk. Because things can be happening. You will think the patient is normal, but the patient is not normal. That patient is already in Vita, but they are talking to you. You say, she was just talking, and then suddenly she just died like that. Nobody just dies. Well, once in a while, but generally, people don't just die. So what are the monitors that I must have? Basic ECG, SpO2, blood pressure, pulse, respiratory temperature, basic. Now, advanced. Typically, those are the ones we also have in our ICUs and the like. They will have end-tidal CO2 or CO2 capnography, and they will also have maybe arterial pressures, central venous line pressures in addition. If you have this one, bam, you are there. I hope you are writing. Don't say you will get the slide. It don't go work. It will not enter here. Okay? I have many slides, thousands. Not up to 10% are inside my head. It's not 5% in my head. It's only the ones I wrote that are in my head. So right, you get the slide, it now becomes Jara. So you need your monitors. Oh, I came from somewhere down up north and we don't have monitor. Sorry. This cannot be done by that. This cannot be done by let us help. It doesn't have any place. No monitor, no ACLS. Number 3, you need hospital protocols. And that don't just include the ACLS protocols, you need checklists. It's not when the person is coding, you start checking whether there's oxygen. You will go and start finding key to the oxygen room. I don't know if that has happened to any of you if you have worked where I worked before. You start looking for oxygen key. Then they go and look for the man to go and pay. You go and pay in pay points. I don't know how people have done it before. They will go and pay in pay point, then take the receipts and go to the people in the oxygen room. Then who in the oxygen room will now bring us that is you don't have ACLS. Okay? So it includes daily checklists. There must be checklists that when you as a nurse are taking over. So that's why I said I will do some of things for the nurses. When you are taking over or handing over, you must check some things. Ambu bag, because you never know. It could be you. You never know. It could be you. It could be your mother, they rush her in. You now start saying you are looking for ambu bag. That the ambu bag is not pressing. Is that time you say ambu bag is not pressing? So you check it. You check the oxygen. So they are standard. I'll give you what is in the standards, some of the standards. You check those things every day, every shift, before every procedure. As you enter the cath lab, as you enter the theater, you must check. Then drills. Every quarter, this thing does not come by, we want to do it. There must be drills. In the theater, you do a drill. Assume it's happening. Everybody should just move. Wham. So if you need to see it happen in, you need to see it happen, I know it's not good to see it, but if you ever see it happen in our cath lab, immediately everybody just moves. The people going to the crash cart move, people going to the monitors move, people going to the defibrillators move, people going to medications. It is like an orchestra. Pram. In 10 seconds, shock has been delivered, drug is going in, somebody is moving this one, pressure bags are up, but you cannot happen if you have not practiced it. If you have not practiced it over, otherwise it will be on top of patient you are practicing for the first time. That should never happen. So you need to plan the drills. So another way to do it is early morning drills. Plan once a quarter, first Monday of every quarter, 8 o'clock. Those for the military. I'm sure you can easily do it. Pam, everybody. Once you are working in the hospital, it's about abomination to work in the hospital and not to do BLS or ACLS. The one you have learned, go and teach them. It may be enough. Number 4, a crash cart. And I brought one here. This is an example of a crash cart. This is not the correct one, but for argument's sake. So this is an example of a crash cart. I don't know whether Vastovas you sell, they have gone. So this is an example of a crash cart. It has a place for connecting gadgets. It has the IV line pole for hanging your IV. It has the place for sharps and the like. And it will have the place for all your drugs, ambu bag, whatsoever. And then some of them also have, if you make it yourself, like the one we make, you just call Iabode, you know. They know how to make it. Just show them this thing. Say, oh boy, run out for me. Put a place for oxygen. They will put a place, oxygen will be there. So once you move it to the patient, everything is there. Glucose, everything is there. Maxolf, lidocaine, and I'll give you the list of things that will be there. You cannot be running around. A running doctor is a bad doctor. A running nurse is a bad nurse. It means that it did not occur to you that this could happen. That is the height of irresponsibility. Okay? Sorry, I'm sounding harsh, Abi. I want to provoke you. I want to make you angry. When you dream, I want you to see me. You're like, you run, and that's what I want to happen. Number 5, you need point of care testing. Basic glucose, electrolytes. Advanced, you need blood gases, pH, troponin, D-dimer. You need that, basic or advanced. Number 6, you need a defibrillator. At the very basic, you need an AED, like I showed you yesterday. And otherwise, you need an advanced one like this. Very expensive. And you cannot charge anybody for it. For those in private practice. Very, very expensive. So this one can act as an AED. It can act as a manual defibrillator. It can act as a temporary pacemaker. So you can pace the patient externally and move the patient till when you can get a pacemaker done. It can, it can act as a monitor. You can connect the patient's ECG to it and use it as a monitor. So this thing, it has paid back. Oh my God. I know some rich people will just put it inside their house, but they cannot use it. I have used this entire Abi. Man, the thing is good. All right, so for those that are looking at it, you've never seen it before, this is your time. Okay, so if you have a good one like this one, and anytime you shock, it brings out a strip of the last things that happened. So it can give you a record of the rhythm that led to the shock, and the shock delivery, and the rhythm after it. So you can have a record for medical legal purposes. That you did what you did. This was the ECG before you shocked, and see the ECG after there was recovery. Very important. So it has a place for a printout by the side. So I think we are showing that there. Abi? Fine. Is that all on that slide? And then others were available. ICU. And if you are not available, you should have already identified a center where you can move your patients. So assuming a patient comes now, you see the heart rate 15. You should know what to do. You should have something like this to pace the person in the interim, and have the arrangement at least to transfer the patient to the next place. CardioCare or anywhere else that is near you that can put in a full care, including access to a specialist. So these are the things. So are you prepared? Is anybody prepared? All right, great. Great. All right, so is this clear? It's clear, be straightforward. It's straightforward. And if we know what we are doing, this is not Tinubu's fault. It's not everything that is a government fault. This we can do. This we can do. Instead of them buying another ambulance or a CT scan or MRI, 2 billion, 3 billion, and they don't have a crash cart. Do you understand? You understand what I'm saying? All right. So those trained personnel, it's not okay to have trained personnel. You must have round-the-clock access to the trained personnel. Not that they are on your book and then one person is on duty today, person on duty 3 days later, and there's nobody between that time. You say, Kai! If your cardiac arrest had happened yesterday, you would have been saved though. Multiple people, trained and retrained, trained intubation, at least you have somebody on access, post-cardiac arrest care, trained transfer personnel when movement is necessary. A crash cart should contain these things. Amiodarone, adenosine. You saw I used adenosine in that case, for that case, and you saw Dr. Amina talked about adenosine for her case, Abi. You should have adrenaline, you should have atropine, you should have bicarbonate, calcium gluconate, dopamine, dobutamine, diazepam. You can see the ones in red, lignocaine, that Dr. Jaffe was talking about. Amiodarone, we don't use them tire. If you never use amiodarone for your patients, man, I think some people have died though. That may sure or may not have died. Doc, have you met Abi and made their own IV? Well, Abi? I did not see him? Not so much. Okay. Beautiful. Yes, they brought a baby to us. You're telling us, Abi? One lady that came with SVT in pregnancy. We treated her IV, I did not see him. When she gave birth, she brought the baby that was, oh, so nice. Oh, we also share the joy. Okay. Laryngeal mask. And this is very important. This laryngeal mask is very important, especially if you don't know how to intubate. Because you can just put it down the throat. It kind of just goes and sits there in the supraglottic area and can deliver air as if you are intubating. So if you cannot do the full intubation or have trained personnel, at least get a laryngeal mask airway. Oropharyngeal airway, like Prof was reminding us yesterday, ambu bag, oxygen tubing. So sometimes what happens is that you want to do intubation. This tubing between here and the oxygen cylinder or the oxygen point on the wall, like we have in our hospital, may not be there. And that's the hollow. Because of that, all your big gadgets, all of them will fail. Just because somebody did not check for that oxygen tubing. It can be the most embarrassing thing. You can't use your own mouth to blow it. There's nothing you can do. Do you understand? So this is why you must check it. Okay? And then sometimes cut down set, intraosseous drill, central line cannulation sets to do that. I think I had to pass a central line this morning. All right, so crash cart, Abi, get one of these. It is sold, or call Iyabode, let him make it for you with catapult, with containers, drawer and container. It's makeable. Good. Number 2, BLS. We did that yesterday, but I will just remind you. Number 1, confirm the situation. Check for safety. Oh boy. Check for safety. Check responsiveness. Check pulse. How do we do it again? First check your area safety, Abi. Our 2 fingers by the side. Those of us that practice are talking. Those people that did not practice are looking at us like this, eh? Or your. So your ear now to the person while your eyes are here. You check. Then what next? Call for help. Help means extra hand, help. Crash cart comes, defibrillator comes, ACLS team is activated. Some people may be 5 minutes, 10 minutes away. Okay. Then compressions, flat surface. It's not here. The board. You guys left it behind. So normally on there should be one flat board that you can put under the patient because the bed is too soft. So you can slide it under the patient and have good CPR for that patient. Okay, then we said 100 to 200, 100 to 120 Abi per minute, 5 centimeters depth, and then minimize interruptions, locked palms. We talked about all of this yesterday. Shock as soon as possible. And the 2 most important things, so if we're writing an exam, what do we say were the 2 most important things that determine, 3, that determine success of BLS yesterday? What did we say? Hey, it's not yesterday and today. Oh. Now this rice, they will have given pounded yam. Next year, pounded yam, please. No, it's not good for cholesterol. We'll give you salad. We said, number 1, a witness arrest by a healthcare professional is more likely to be successful, Abi. We also said quality compressions, and we said time to defibrillation. The time it takes to defibrillation is critical for success. And I had one case I had to just skip over it. The time we measured the time was about 15 seconds. We worked from 8 a.m., 1 a.m. We were doing maybe our 7 case. One of us, I was the one sleeping off. I slept off on one side. The people were walking. I said, okay, I'm coming. Me and Dr. Dafe. They just, Pram, VT. The guy was off. They just hit the distance. I did not even know what happened. Of course, I told the spinal level, Abi. Pram, I just grabbed it. Boom. The man just came back. But when we checked, because we had the hemodynamic monitor, which gives a full record on computer, 9 seconds. Okay? Pam, the man came back immediately. Okay? So very, very important. The time to defibrillation, quality compressions, and then a witness arrest. All right, so assessments. In the assessments, we are trying to assess and reassess the ABCD. Airway, breathing, circulation, disability, and any of exposure. So you are doing your CPR now. As you are doing your CPR, so the next step is that ACLS. You are doing your CPR. Senior people have come. Typically, this is the job of the more senior person. He's checking advanced airway. Can we get an advanced airway? He's checking oropharyngeal airway because you did what you need to do first. He's calling for anesthesia or whoever that can do the airway manager person. They cannot find, they're getting the radial mass. Airway is there, check all of that. Is the ventilation proper? Check the person that is pressing, how are they doing? Oxygen, check all of that. Check the monitor and see waveform capnography. This waveform capnography, if you have an advanced monitor, most of us, some people have it in their hospitals. It's there, you just don't know how to use it. It is the most important and the most sensitive marker of how good your CPR is. What do we say? Capnography is the most sensitive marker of how successful your CPR is. It is not that the person is pressing. When you check the amount of oxygen, of carbon dioxide being retained, that helps you. Okay, then secondary assessment. We check for the 5 H's and 5 T's. Does the person have, is it hyper? It's supposed to be hypo, sorry. Hypovolemia, they need fluid. Sorry, not hyper, sorry. Hypoxia, they need oxygen. Acidosis, hypo or hyperkalemia, hypothermia, you need to check. And especially in children. In children, hypothermia is the #1 thing. Before you do anything else, you will never be successful if you don't cover. If somebody is drowning from a pool, you brought the person out. As you are doing CPR, ACLS starts, you will bring blankets and cover the person. So that will be part of your ACLS. Then pneumothorax, tamponade, toxins, then PE or CAS. So sometimes, it can not happen to me, people are doing CPR and they are moving straight to the cath lab and they continue CPR and you start your PCI. And sometimes you are successful. You will get the lesion, open up the lesion, blood flow starts moving, the patient comes back to life. Okay, so if you think it's an MI, you want to, especially if they have an ECG before and you notice that one, straight you are moving to the cath lab as you are doing the CPR. You continue the CPR while you are doing your PCI and you could be successful. All right, so number 4, we are getting deeper now. We are getting deeper. Number 4 is crisis resource management. There are 4 components of this. You need to write this. 4 components. Number 1, leadership. Number 2, communication. Number 3, preparation. Number 4, team dynamics. Very important. Sometimes we think we know it, but we cannot work in a team. You don't know ACLS. You cannot work ACLS. Okay, so what are these components and what are the details around these components now? Okay, so leadership. One person must be Oga. When there's a crisis, you cannot have 2 Ogas. The only thing that has 2 heads is a monster. Only a monster has 2 heads. One person must assume Ogaship. So normally the most senior person, the person that went for the latest course, so all of you now automatic Oga. So learn well so that you will not go there and now messing up. So you coordinate all the tasks. All communication must pass through the Oga. So somebody says, let's give adrenaline. He will not call the nurse to give adrenaline. He will tell the Oga who is now putting everything together and say, okay, give adrenaline. So there is not counteracting everybody talking their own. Anesthesia is talking, surgeon is talking, professor comes in is talking, nurse is talking, craziness. That patient will die. Okay, so coordinates, everything passes through, that person puts everything together, collates the strength and the experience of the entire team. I know you are good in there's one guy in CardioCare, that guy can do CPR and do compression. Hey, Jesus. After the guy comes, everybody clear. The guy will just come like this. Boo, 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 boo. Hey, then all of us cannot continue. I mean, you know now. Boom, all of us cannot continue that things. We know that one is taken care of. Okay, so you know the strengths and of the team. Number 2 is communication. All pertinent communication must go through the team leader. So for example, one nurse will say, this man is like, I saw him take something, he said he was tired of life. He's not telling that nurse. That communication not pass to the team leader. You are thinking of other things. You are thinking MI, you are thinking big things. Meanwhile, you not think of a toxin. So it must pass through the team leader to advise. Every instruction must be read back. Give atropine 1 milligram. The person that you want to give must read back. Atropine 1 milligram to be given. Otherwise, there will be error. So sometimes I will say something. When they say it, I say, how? Like this lady that said, I said I will teach pacemaker ECG. I did not say that. Okay. All the extraneous personnel will cause you trouble. get them out of the room. There will be unnecessary videoing, put unnecessary pressure on you. Debrief the team after the whole team for learning points. You need to ask, after the patient survives or doesn't survive. The only way you get better is that you sit down and say, what did we do? What could we have done better? Oh, that oxygen that finished what we were doing. It should never happen again. Oh, we did not have sugar. We have to go down to the pharmacy to get 50% glucose. 50% glucose is not on that crash cart. Let's add it. Do you understand? That is how you build the team based on your experience. Number 4, prepare your everything like we talked about. Number 5, team dynamics. Share knowledge, constructive feedback. That is not the time to shout at people, but sometimes I shout too. I shout. When we finish, I'll tell you sorry. But you should not be shouting. Okay? We should not be shouting. You should be constructive. If a junior has something to say, that person should say it constructively. Oga, this is not the time to give the education. This is a different. I don't think that it is a good time to give. You get that's constructive, rather than saying lidocaine in this case. Then before you know it, egos now start fighting. Do you know who I am? BSc, MSc, HIV. All right. So very important that the whole team does that. So number 5, now we'll now enter the meat. Rhythm identification. And because you need to identify the rhythm, you need to know what therapy to give, electrotherapy and medication. This is the main meat of ACLS. If you cannot identify the rhythm, that's why I say if you don't have a monitor, how can you identify the rhythm? It means now witchcraft they do. Now VTAC with this. The way the man is doing his mouth, it go be VTAC. All right, so successful ACLS, besides those things, starts with the correct identification of ECG rhythm. Okay, so what are the ECG rhythms? You need to write. These are simple. You will not get it anywhere like this. Trust me. I took some time to make it breakable. So there are 2 basic types of rhythms in ACLS. One is cardiac arrest rhythms, which have no pulse, and 2 is non-arrest rhythms. The patient is still alive, the pulse is present, it may be too fast or too slow, but there's a pulse. So those are the 2 basic types of rhythms. 1, cardiac arrest, and 2, non-cardiac arrest. Those are the ones that say, the patient was fine, he even made a phone call himself. So, but ACLS should have started then. Okay, so, under the cardiac arrest, we have VFib and pulseless ventricular tachycardia, pulseless VT, and we have pulseless electrical activity and asystole. The ones on number 1 are shockable, number 2 are non-shockable. So when somebody has a cardiac arrest, they have either 1 or 2, they don't have a pulse. So if you see VT and you have no pulse, it's a pulseless VT or a VFib, or they have pulseless electrical activity. I've seen people, because they watched Grey's Anatomy, they say flat line, oh yeah, let's stop. He has died. Can you not remember that film? When they were doing that, just a ping, it's over. Oh, that's sorry. No. Continue your CPR. Asystole is just a cardiac arrest rhythm. And sometimes you will do your CPR and your everything, and it will revert back to VFib, and then you will shock, and before the patient is back. You don't give up like that. If you assume it's your father, assume it's your mother, assume it's your brother. Okay, so these are the 2 sets of cardiac arrest rhythms. What are the non-arrest rhythms? Number 1, narrow complex tachycardia, like Dr. Amina showed us this morning for one of our cases. And number 2, wide complex tachycardia. And number 3, bradycardia. So the patient comes, like the case we talked about this morning, pulse was 24. Abi? That is a non-arrest rhythm. The pulse was still there. The man is still there somehow. If he's not set up, the man is still there now. He's not gasping, there's nothing. I will check again, vital sign. He's sleeping, let us allow him to rest. He said he's tired. Have you ever heard those kind of things? The nurse said that he's tired, I say he wants to rest. At pulse of 30, which kind of rest now, hotel? So there's nothing like that. You don't rest in the hospital. So you have the cardiac arrest and non-arrest rhythms. Non-arrest rhythms are these ones, there's a pulse. While the cardiac arrest rhythm, there is no pulse. Good. BLS comes for the cardiac arrest rhythms. Non-arrest rhythms is where we normally miss it. Somebody checks vital signs, gets 180, and continues with the next patient and next patient and next patient and next patient. Then they say something happened. How? You are a killer. You are the one. Because that person has entered a non-arrest rhythm and should have started ACLS. Called the alarm and started everything. Okay, so next. So let's start with the cardiac arrest or no pulse rhythms. So, this is cardiac arrest, no pulse. What ECG pattern is this in cardiac arrest? Hello? There's no pulse. You put on the monitor and you saw this ECG. What of these answers is A, B, C, or D? Is there E? Huh? Try, talk out. That's how you do it. It doesn't come by. If you try, you fail, you get it the next time. The ones I failed, I get better. In fact, I never forget. Pulseless ventricular tachycardia. Is this a ventricular tachycardia? We say ventricular tachycardia typically was what? Wide complex, remember? And it's a tachycardia, meaning it must be fast. What is the rate in this case? Like 75 now, Abi? Good. So you will see it on the monitor. You can see the 75. So this is pulseless electrical activity. Is this a shockable or a non-shockable rhythm? Non-shockable rhythm. It's a cardiac arrest rhythm. They don't have a pulse, but they have a normal looking ECG. Follow me, oh. This is very important. This is very important. Just stay awake for the next 30 minutes. Let's just wrap this thing up. Can I take it again? Patient has had a cardiac arrest. What did we define cardiac arrest as yesterday? No pulse, no respiration, non-unresponsive. You connected your CPR, you connected your monitor, and you got your monitor and you saw this one. What ECG would this be? There's no pulse. So this is a pulseless, there's electrical activity, but there's no pulse. So you continue your ECG, your CPR completely, okay, until it changes. What is this one? What is this one? AC Solami, nothing is happening, I mean, barely anything happening. So this is a cardiac arrest rhythm. Is this a shockable or non-shockable rhythm? Non-shockable. We don't shock AC Soli and we don't shock pulseless electrical activity. Okay, you exclude your 5H and T's. For the non-shockable rhythms, you can give adrenaline 1 milligram, repeat adrenaline every 3 to 5 minutes after checking rhythm. So every 3 to 5 minutes, you check the rhythm again. So that you have to stop 1 minute, check the rhythm, continue CPR, recheck every 2 to 3 minutes, and then you can give your adrenaline every 3 to 5 minutes after checking rhythm. Okay? Hello? Easy? Straightforward? We will soon come where we'll have to put it together. You know how I used to do? I will teach you the basics, then we'll now throw you inside the deep water. So, no pulse, cardiac arrest. What is this? Huh? I can't hear you. Some people are just saying, some people are just looking like this. When it happens to you, that's how they look too. You better try now. Ventricular fibrillation, Abi, jaga jaga, everything jaga jaga. Poor man scatter scatter. Where is that boy guy himself? Idris. So, but you must check that the ECG is fixed well, Abi. Okay, so ventricular fibrillation, cardiac arrest rhythms. What is this one? Ventricular fibrillation as well, Abi. So you see it. Sometimes you send people to the ECG room, they are doing ECG, and this is there. Patient just go and just look like this. They say no, he's sleeping. And they are seeing this on the rhythm. You should kill everybody there. Okay, so what about this one? Ventricular tachycardia. In this case, you must qualify it. Because ventricular tachycardia can occur where there is a pulse. So this is a pulseless ventricular tachycardia. The treatment for a ventricular tachycardia with a pulse is very different from the one without a pulse. The one without a pulse is a cardiac arrest, Abi. The one with a pulse is not a cardiac arrest. They may still be talking to you. All right, so shock, adrenaline, continue, adrenaline, shock. Unlike the other one, you are not shocking. In these cases, these two categories, you shock, you give adrenaline 1 milligram, every 3 to 5 minutes you repeat adrenaline, you recheck the rhythm, and then you give IV amiodarone after your second or third shock, like we were talking about in the electrical storm. So if you don't have IV amiodarone here, and it's that time you say, go to Kuliara, what's the name of the pharmacy that is here? Go and get your this pharmacy, it's all over. It's all over. So you should have it there. Beautiful. All right, so cardiac arrest happens, check rhythm. Asystole or pulse electrical activity, adrenaline plus CPR, continuous CPR. If you have pulseless VT or ventricular tachycardia, shock, CPR continues, adrenaline, and then you check again every 3 to 5 minutes, adrenaline every 3 to 5 minutes, check and treat for 5H and 5Ts. After the second or third shock, add IV amiodarone. 150 or 300 milligrams given start. Beautiful. Is it simple or not? It is simple, just that you don't know it. And you don't need to cram this one. You need to write it down, put it in your head, think in your mind, if this happens, what will I do? If this happens, what will I do? But when it happens, you will not have time. Google will not help you that time. It is so fast. It is so fast. But I tell you, once you are successful, it's the best feeling in the world. No amount of money can compare. Well, maybe about $1 billion, but no amount of money can compare to it. All right, so reversible causes again. Remember we talked about that, and thrombus and stroke. Now, thrombus, you can have an idea sometimes of some of these things. Maybe before they had the ECG, they had chest pain, they had angina, they had troponin. As they're having that one, inside your ACLS, going to the cath lab will be part of it. Adding aspirin and clopidogrel, like we talked about, will be part of that, your ACLS. You will not have to give all those drugs and continue. The patient will never come back. Okay? So you must find the reversible causes and try to treat it while you are doing that CPR or the advanced cardiac life support. So I think we've gone through this our algorithm. This is a patient I told you about, 1:50 a.m. Patient, he just went like this. Wham. Or just lying down on the bed after the procedure, he just did like this. Then we looked at it, VT, Oga. So time to CPR and then shock, and then he came back. This is how all of us were moving around. We set up our IV amiodarone, set up whatever. Then the man now said something that I cannot forget. Why are all of you making noise? I don't know whether to shout at him, but the man had just come back from near death, you know. Say people should keep quiet now. You're making too much. All right. So, for the cardiac arrest rhythms, we've talked about shock and non-shock, right? And we've talked about shockable rhythms and the need for amiodarone. We talked about lidocaine and then check the 5 of T's. For the PEA, the non-shockable, CPR, adrenaline, sometimes we add atropine and then we reassess and we come back and start. Now, for the non-arrest rhythms. For the non-arrest rhythms, these 3 rhythms, wide complex, narrow complex, or bradycardia, our decision will determine whether they are stable or unstable. We define unstable as the presence of hypotension, shock, chest pain. Like Abunaske said, she had chest pain and palpitations. You remember? In the morning, for those that came late, you had chest pain, that is a sign of instability. Okay? Chest pain, heart failure, altered sensorium, that is a sign of instability. You must act. So what you do for stable or unstable determines on whether. So if it is stable, typically you give medications. If it is unstable, you cardiovert. Cardioversion simply means you take this, you cannot use an AED for that. That is why you need a better defibrillator. Use this kind of one. You take, you can video this. So you take this, you turn it on, you turn it to your manual defibrillator. Have I done it well?
Connect pads cable.
Okay, yes. You turn to your manual defibrillator, then you select the energy that you need. Typically 50 to 100 for the cardioversion, sometimes up to 150. And then after that, you will now sync. You can see this button that says sync. Cardioversion is different from defibrillation in that it delivers the shock on the QRS. Defibrillation delivers the shock anywhere. Cardioversion is lower dose. Never, ever, ever, ever defibrillate anybody that has a pulse. Write it down. Never defibrillate anybody that has a pulse. You will kill them. Again, never defibrillate anybody that has a pulse. In these cases, remember they are non-arrest rhythm, so they have a pulse, right? It's just that it's very fast. Now they are unstable, they're having some instability, they have some chest pain, altered sensorium. You need to shock them. Check that they have a pulse. Sometimes just before you shock, you check they have lost the pulse, they have gone something else, they have gone into a full cardiac arrest rhythm. Cardioversion will not work again. You need to now defibrillate. But if they have a pulse, never defibrillate. And that is the major difference between pulseless VT and VT. In this cardiac arrest rhythm, where there is no pulse, you defibrillate. While here, where there is a pulse, you cardiovert. Don't forget. Pulseless VT defibrillate. Defibrillation is a higher energy, typically 200 and above. And it is at any time of the cardiac cycle. That's defibrillation. While cardioversion is a lower energy and it is directly on the QRS. So the machine will sync. When you press shock, it will wait for the next QRS and then to deliver the shock at the exact time. Do we understand? Hello, should I go over it again? Anybody that has a VT, you can see VT on the monitor. If they have a pulse, do not defibrillate. Thank you. People are listening. You may cardiovert them because they have a pulse. Lower Joules and you will synchronize your shock. While if they do not have a pulse, they are typically in cardiac arrest, you just defibrillate. So if you don't have a manual defibrillator like this, where you can set all of that, you cannot cardiovert. You will only be able to defibrillate. You only put the pads. And that means that if you put the pads and it senses a VT, whether there's a pulse or not, that thing will shock that person, Abi. So the AED will shock. So you need to cross-check before you do that one. And you cannot cardiovert. All right. I think that is clear. Clear? Any questions so far? Should I slow down? Okay. Thank you. So emergency response, determine whether it is shockable rhythm or not. I've talked about all of these ones. Go across all of that. So for the non-arrest rhythms, don't worry, we'll soon go, then we'll enter mega code. We'll take some cases together. So adult tachycardia with a pulse. Typically, in your mind, think that patients with a pulse greater than 130 or heart rate greater than 130, they are likely already in trouble. You need to have an ECG for everybody. So in our center, it's an alarm sign. Anybody that has a heart rate or pulse rate greater than 130, you must call an alarm. Let everybody know that there's something happening here. It could be a pregnant woman. It could be somebody in theater, going for theater, after surgery, whatsoever. We use 130. It's a little bit wide, but it allows us at least. Normally it will be from 140, 150, but from 130, at least let us come and know that there's nothing. So we ask ourselves whether it's stable or unstable. If it's unstable, that is they have hypotension, Abi, shock, chest pain, altered sensorium. What do we do next? Cardiovert. So anytime you have a tachycardia, fast, patient is unstable, what are you going to do? Cardiovert. Unstable, patient has lost consciousness. The pulse is tachycardia. There are two types of tachycardia. What are the two types of tachycardias? Hey. No. Tachycardias in non-arrest rhythms. What are the two types? Wide and narrow. Thank you for helping me. Thank you. So, after you cardiovert, you continue your medications. Now, if they are stable, whether wide or narrow, most times for narrow, you first start with your vagal maneuvers like Dr. Amina described, and then you can now, or you go straight to your meds. Sometimes we start, sometimes we go directly to meds. Okay? And if it is wide, well, it's more or less a similar thing. Okay, make sure you have all of these. Get specialist inputs, oxygen access, monitors. If you do the wrong thing here, your cardioversion, your medication can turn something directly to VFib. What was non-arrest before, you can turn it into an arrest rhythm. Okay, the patient will just lose the pulse immediately. All right. So, tachycardia with pulse. The difference between narrow and wide, the same kind of thing we do. So whether or whether not, once you have a tachycardia, 50 to 100 joules is what we typically use. Most defibrillators are biphasic. You will not find monophasic again on the market. Okay, except you're having a very, very old one. I think those days they used to have one before. So that's what you use. But if it's irregular and it's narrow, you will use a higher amount. All right. Again, never defibrillate when there is a... Thank you. All right. So, white complex, amiodarone, consider adenosine. For narrow complex, vagal maneuvers, IV adenosine. Now, IV adenosine is a drug that lasts only 3 to 6 seconds in the body. 3 to 6 seconds. So if you give it lazily, you just come and you just give it like this. Before the thing reaches the heart, it will finish. So you need to give it very fast. Typically, we use a two-way cannula. That is a two-way stopcock. We will first practice with fluid. Give, then I give saline to flush. Do you understand? Give, I give saline to flush. We'll practice 2 or 3 times. Then we'll now say, okay, it's time. We'll now take the adenosine. As soon as I give, you now give saline to flush. So that, pop, pop, it has gone. Within 3 seconds, it has come whatever havoc, it has stopped whatever it is and come down. And if you made a mistake too, within 3 to 6 seconds, it will finish on the body. Whatever has happened, has happened. Okay? All right. So 6 milligrams first, and then you can repeat as a 12 milligram dose. You typically don't do more than 2 or 3 times. Okay, so if you give 6 the first time it did not work, the highest you go to 12 milligrams. So if it's bradycardia, what will you do? Monitor, observe, treat any reversible causes. What are reversible causes? Drugs, including some eye drops, timolol and the like. They could have smoked something. Okay, treat reversible causes. That's if they are stable. I mean, remember the stable or unstable. Now we are now talking about whether they are unstable. In unstable patients, that we now decide. Number 1, atropine. Atropine, one of the things in your crash cart, remember. Patient now pulse is 20, 22. You took the patient in. I did one PCI for a patient. Pulse just dropped. Bam. Luckily, I was ready. Gave my atropine, started my transvenous pacing. Pram fine, finished the case, removed everything, came back fine, patient went home. But without that, it would be a different story. So some people are operating cath labs without those things. I don't know what they are doing. Okay, so you have the atropine, there you give 1 milligram every 2 to 5 minutes, total of 3 milligrams. Okay, then if it's not working, you can now go to transcutaneous pacing. Now what do you do with transcutaneous pacing? Did you guys come with the pads? In transcutaneous pacing, you put your pad, preferably one at the front and one at the back. So you put your pad, one at the front, one at the back. You have this kind of monitor, Abi. By the grace of God, you have it. You turn it to pacer, in this case here. It now turns to pacer. You can now see the pacing rate and the pacing output. Can we see that? Is it showing on the screen? So we can now change the rate to what heart rate we want. And it will progressively, so this one now is preset at 70 and an output of 30 volts or 30 milliamps. It causes a little shock on the person's body, so you may need to sedate them a bit because it's a little uncomfortable. But once you have done that, you now have a steady heart rate. You can now transport the patient in ambulance and move to where they can get a pacemaker inserted. Are we together? Very, very important. Or if it's just a temporary thing, maybe you gave a drug or something, you can continue this until the thing wears off and the patient comes back up. Okay, so that's what you do. So transcutaneous pacing. If you don't have transcutaneous pacing, you don't have transvenous pacing, epinephrine infusion, adrenaline infusion, put it in infusion, or sometimes it's not working. You might either add or change the dopamine. Put 2 of them. Let them be running. And then you should at least raise it enough. So you can now use that IV fluid now and get the person. That is why you must have adrenaline also in your crash cart, Abi. And that is why you must have dopamine also in your crash cart. So if you have these ones, it's preferable to use a syringe pump. Put it on a syringe pump, titrate it correctly, and it goes in that way. Okay. Is there any question?
Yes, sir.
Please emphasize the need for anesthesia before defibrillation. There is no need for anesthesia before defibrillation. Patient don't expire. Defibrillation is for what? Cardiac arrest rhythms, Abi. So anything you do to them, you tell them sorry later. I've shocked somebody before. After a while, you started smelling, you know how hair has burnt, you know that kind of thing from the person's chest. When the man came, I said, thank you. I said, you smell his own hair. Okay, so there's nothing. What we do anesthesia before is for cardioversion. The patient is relatively stable. We want to cardiovert. We give them, or even this pacing, you give them some lights, midazolam, maybe fentanyl or something. Just lights, conscious sedation. And then you can now start, so they don't feel too much pain or discomfort while you are doing whatever you are doing. So apart from that, that is what you do. All right, so we've gone through all of this. So airway management and ventilation, simply you want to take your oropharyngeal airway. Like I said, if you don't have this, you have to get a laryngeal airway mask that you can just slide in. It will go to this supraglottic area and cover both the esophagus entry and the airway of and you can ventilate the person almost as if it is an intubation. So if you don't have to intubate, get a laryngeal air mask and have it there, or you have nobody that can do that. All right. The only people that should intubate are those that are familiar. They must be able to have greater than 95% success with 2 attempts. I've driven one anesthesiologist from my theater. What nonsense? Wait, I'm coming. Wait. I'm still angry. So chest compression should not be. So the person should be able to do it 2 attempts if I've gotten it maximum. And they should do it in 5 seconds because you must not stop your compression. So if you say, stop, I'm coming, I want to see. Wait, I'm coming, let me see well. Let me see the light well. The person must be able to do it, will have done it enough times. Okay? Video laryngoscopy is encouraged. Waveform should be used. Entire CO2 should be used. If you are delivering oxygen, nasal cannula can give at best 41 to 44%. Anything above 6 liters per minute on a nasal prong or nasal cannula, you are just wasting your oxygen. It cannot give anything beyond 6 liters per minute. If it is face mask, you cannot cross 6 with 10, but the maximum is 60% oxygen. Now, when you use reservoir bag like this, or a face mask with a rebreather bag, that is when you can get up to 100%. You can see this reservoir bag that they wrote 2,000 mils on it. So this one now, if you put it, you can truly give 100%. What you need in this patient most times is 100% oxygen. It's 100% oxygen when you are doing whatever you're doing. All right, we're going to get to some exciting parts now. Post-cardiac arrest care, I'll not waste time about it. Typically, intubate most of them, check their stability, monitor their blood pressure, keep them, obtain a 12-lead ECG. So that patient move to the ICU, you want to monitor all of those things, and then sometimes you induce a coma, okay, and do other care. If there's a STEMI, as soon as you've done that one, patient go to the cath lab, you need to open that thing. You don't have a cath lab, what do we say you can do? What do we say you can do? I didn't say pray. Thrombolysis, if it is within the time place, tenected place or alter place, if within that time frame, preferably get a specialist input, even if it's on phone. Oh, I have this case, just get that 2 minutes conversation can help direct the care before you now transfer the patient to a cath lab. Okay, so maintain hemodynamics, get a specialist, ventilate, specialized interventions, PCI, I showed you some. IABP. I think CardioCare is the only one that has IABP in the entire northern Nigeria. I think there are only 2 in Nigeria, to my knowledge. CardioCare and somewhere in Lagos. Then temporary and permanent pacing. You can do transcutaneous, like I showed you. We also have the transvenous temporary pacing, and then we can also put a permanent pacemaker if the person needs that. And then all the other devices that are there. This is a patient, for example, hypertensive diabetic, referred. What is this reading? Referred from a hospital here in Abuja. Gang, gang. This is not real life. Ventricular what? Tachycardia, no fibrillation, Abi, because you can see it. It is constant, it is regular. What is the rate? It's almost 300, Abi. It's like 250. It's like 300 divided by 1.5, Abi. So it's like 250 or 180, like that. Very fast, going on. So by the time she got to our hospital, this is what we saw. She came, the cardiologist there just come and say, I beg, I don't get energy. Please. So just send the patient. So when I got to this, did the ECG was fine. So, but you know that it can happen again. So, ICU. Post-cardiac arrest care is very critical. That the patient has come back, you say, oh, celebrate, they will die again. So, you have to do the proper thing. So, we now took her in, after everything has calmed down. This, remember I told her when you shock, it prints out the thing for you. That is the printout you are looking at. Can you see the number here? Shock number. Can you see that? Shock number what? 8. That's how many times. That is an electrical storm that Dr. Edafe was telling us about. This is an electrical storm. We have to shock up to 8 times. Shock, then give amiodarone, give lidocaine, then we put an ICD in. She's still alive 2 years after now. Another time she came out another electrical storm, but this time the defibrillator was working before she came to the hospital. Then we gave drugs. We thought continued working. It came calm. She's done another 1.5 years after that. Yes. It was actually a defibrillation with a low dose. It was a low dose defibrillation because she was pulseless, unstable, everything. It was actually a defibrillation, but we used a low dose defibrillation because we were cardioverting, but we are giving multiple times. We decided that can we not be successful with a lower energy? So once you have this kind of ones, you can adjust what you need, and then you can do that. So you can see on the monitor. Can you see the VT? Hello? Look at it because you have monitors in your place now. You will see this thing if you look clearly. Your patients are having this on the ward. I am not seeing it. It turns to VT. Can you see when it turns to a normal reading? The device was in situ, so the device shocked at that point in time, and then it turned to normal. Can you see that? This is why this device is now life-saving. No device, you'll have to say, call a code before you start coming. Hey, where is the crash cart? Bam, Otilo. All right, so she came back in the clinic, everything is fine. Okay, another man, same thing. I think we talked about this one. So this is how we put an ICD. Under the clavicle, we do cleaning, then we anesthetize the area. We go through the axillary vein, and then we pass our leads in, typically single or dual chamber, straight to the heart, and we put it back in. Very simple procedure. You can do it now. Then we put it in. Okay, we will likely have a master class for that one day. So we put it in, and then we connect it to the battery, put the battery inside. Now, this one now starts. While it is there, it is constantly monitoring that ECG. So every patient at high risk, especially those with heart failure, people that have had a sudden cardiac arrest before, you typically, and especially the one that it was cardiac in origin and you could not find it, you need to put that one. Otherwise, when they have the next one, they may not be lucky. So they must have it. It will constantly monitor it and then do that. So let's do mega code. Are we ready? Yes, sir. Good. Case 1. By the way, this is timed. So remember, you have just a few seconds. Everybody, I need you to talk. Even if you don't want anybody to know that you failed, just talk under your breath. But if you don't talk, the other time is coming. I will not be there. Nobody will be there. You will be OYO. Okay, 52-year-old, collapsed at a rally. He arrives at your hospital. Steady pulse, blood pressure 60/30, SpO2 95%. What are your initial steps in management? 1, 2, 3, or 4? Some people are not talking. Choose one now. If you fall, if you fail, you fail. That's it. There is no consequence now. Anything you fail now, you are unlikely to fail again. Very unlikely. And if you chorus with other people, you have not learnt it. Oh. People at the back, what did you say? This campaign rally. Okay, so we think it is 3. This was the ECG for the patient. So you came from ACS. So you said, come on, bring an ECG. Do you know who I am? ACS graduates. All right, what is your initial management after seeing the ECG? The political rally has started. The first one, everybody was just like, ah. Somebody said 3. Somebody said 4. Somebody said 5. Which one is 5? I don't know, Abi. Somebody said call a priest. Let him, let him go to heaven in peace. All right, so 3, cardioversion, right? Why do we choose cardioversion and not defibrillation? Thank you. Thank you very much. What is the dose of cardioversion? Are you sure? Call a friend. All right. You are telling your cardioversion. I mean 50 to 100. Now the patient has now lost a pulse. What is your next step? Are you sure? Are you very sure? Good. Some people are listening. So, like VT, once there's a pulse test VT, it's now time. Make sure to shout clear before you shock. Clear, and everybody in the room must shout clear back. Nobody should say, okay, I can hear. No. They will shock you down. Okay, you finish that one, still nothing. Still no pulse. Blood pressure 40-20. Now, SpO2 query. What are the following medications should we use for pulse test VT? Yeah? Yes? There's someone. All the things I've talked now. If you're not paying attention, Dr. Rama Hafa, what's the answer? You think it's 1? Are you very sure? No. $1 million goes to me. I told you to call a friend, he refused. All right, so typically initial dose for this is 300. It's 300. We use 150 for SVTs and for the other ones. Typical dose is 300. Okay? It's not very easy like that, Abi. No, even when I did it, I failed too. So you do it once, twice, and you say, oh, it's true. Then you do it again, you keep on putting yourself under pressure. Now, normally, this test, I lifted it from somewhere. There's a timer going off. So, if the timer ends before you answer, it will just say, bam, you have failed, patient has died. So, it's like 5 seconds per question. So that you can keep your heart checked. Okay, fine. So, mainstay, during this stay, after you administered 1 milligram, amiodarone 300 milligrams. The initial dose of amiodarone is 300 milligrams, followed by 150 milligrams if additional doses are required. What we typically do is we give 300 milligrams, and more often than not, patient is going in and out. We now put a maintenance dose straight to continue. There's a way to calculate the maintenance dose for the patients. Case 2. This was the one on the Tedave sheet. Collapse going the more. What is the reading? Somebody say VT? Fib. Okay. Ventricular fibrillation. Great. Case 3. Patient with NSTMI. What is this? Ventricular tachycardia. Beautiful. Okay. So rapid, regular, no P waves, QRS, could be monomorphic or polymorphic. Case 4. 72-year-old alter sensorium. Dizziness this morning. Getting more confused during the day. Arrived at Chigozie Physiotherapy Center. Because they have been paraded as a doctor. They say, doctor. Blood pressure 458. Heart rate 44. Respiratory rate 18. SpO2 90. What arrhythmia is this? Try now, even guess now. You didn't say anything, guess, even just choose one. Kalo, in, pin, settle, pin, in, pin, out. What did you choose? Morbid type 2, are you sure? What did you say is type 2? Type 1 is which one? It's coming, and doesn't come. Type 2 is just drops occasionally, right? Okay, are you sure? 2nd degree. Also type 2, Abi? It's prolonging, no? It's prolonging. 11 a.m., 2 a.m., 11 p.m., Abi? 2 a.m., 1 p.m. Abi, it's not there. Let's look at it together. This one is short, Abi. This one is longer than this one, Abi. This one is longer than the next one. Then this one is not show up at all. Then you come back again and start again like that. Mobis type 1. Beautiful. Okay. Elevated respiratory rate, SpO2 92. What's your next step of management? CPAP, endotracheal intubation. Intubated man. Chikozie, intubated man. Chijioke, sorry. What? Choose, yes? She said number 1. She said number 1, that's what I will do. Patient while not that experience, you have something, she just gives something to help with the SpO2. Wife confirms that he's not on any drugs. Remember we said that you do for reversible causes, Abi? Bilateral IV access is contained. What medication can be given as an initial therapy? There are 4 options. Choose one. She said number 3. Are you sure? Call a friend. Very, very sure. Put your house on it. Sure. She put her house on it though. I had a house this night. All right, 0.5 bottles of adrenaline, right? Atropine, sorry. Atropine was given. Rate remains unchanged. What will you do next? It don't work. Some people are not even trying. They're just looking and say, let me not fail. You will fail one day. Fail here. Number 3. Very sure, 3 milligrams, total dose of 3 milligrams, further interventions should not be delayed for the admission rate. So get your atropine and give. Now, you gave second dose, heart rate went to 75 and went back to 41. What's the next best step? Cardioversion. Oh, okay. Okay, good. Transcranial spacing. Okay, so cardioversion spacing is not available. What can you use in this alternative? How many have transcranial spacing? How many have transcranial spacing? Nobody. Jesus. Okay. So what will you use that you don't have transcranial spacing now? Pray, rub their back, tell them to. Two, 3, 5, 8, 10. Either 1 or 2. Depending on one of you, you say, well, I don't know one of these ones. Give them both, Abi. Number 4. We said epinephrine or adrenaline, Abi. Yes, that's what we said. And then we said, what else can you add in its place? Dopamine. Can I add it on top or either or if it's not working? Okay, you started it. There's mild improvement in vitals. Remains symptomatic. CardioCare is called. What's the next best step? Is their business. You are going to give CardioCare. What they do? Let's transplant the heart. All right, so prepare for pacing, okay? So what you have given is not resolving symptoms. You have removed all the temporary times. You use that to prepare for transvenous pacing. It could be temporary or permanent. Case 5. Diaphoresis, mid-sternal chest pain, ready to arm and jaw. Next best therapeutic first steps. Three. Okay, so typically give 300 milligrams aspirin. We normally add other things too. Aspirin you can see reduces motility and mortality. The aspirin here should not be swallowed. It's preferable to be chewed. This is not the one you say they have ulcer. It's not like that. The only time you don't give aspirin is when they have actual aspirin allergy. That is when they take aspirin, they break out with boils, with hives, with ulcer. That is the only time. Not ulcer. you will give it. If they have that one, you give them jealousy or what was the other one? Or hair, whatever it is you give. Okay, so this is the ECG. ECG has been done. Interpret the ECG and choose the best therapy. 1, 2, 3, or 4. This is what we are saying. Not come they call me for night, oh. I walked through last night, I walked throughout today, I will be sleeping. I will not hear your call. The next day I will call you, you say, sorry sir, it has happened. But if you call me and say, sir, thank you so much, I use it. What is it? She said what? 4. Why did you say 4?
Because there's ST elevation in leads V1, V2.
All right, good. Anterior MI, contact cardiology for lithium therapy and angio, correct. All right, so V1, reciprocal depression. So sometimes you see this depression in another side of the leads. So typically you consider for that. This patient presented 150/80. So all of this still contribute to as still part of ACLS. Remember with our definition, it's either a rhythm that causes cardiac arrest or will cause. So this is why this is here. If you don't do anything about this patient will die. Okay? Except sometimes some patients survive. So what can we see? What? So what's the answer? 1, 2, 3, or 4? 2. Are you sure? Are you very, very sure? She has received my surgical residence, hypotension, 90/50. What drug did we say during the case review this morning that we should be careful in inferior MI not to give? Nitrates, Abi? Okay, so 2 IV fluid. So typically you have to give some fluid bolus. When you have inferior MI, they did that fluid bolus. And we gave a case of inferior MI this morning. I think Dr. Fatima, that's the one you presented, right? And you saw when the blood pressure dropped after, we gave fluid bolus, we held antihypertensives, blood pressure came back up, and patient did fine. All right, so S elevation. She now has a palpable pulse. After you went back to check, you just went to go and piss. Then you came back. You now look at the monitor. The nurse was on Facebook. Then you know, what are you doing here? So what's the next step? Are you sure? Hypotensive, unresponsive, hypoxic. If somebody is unresponsive, hypotensive, is that stable or unstable? Unstable. Okay, so you have to cardiovert, okay, and prepare to intubate. So defibrillating someone with a pulse is life-threatening. Again, just to remind you. So this person has a pulse. Do not defibrillate. After cardiovert and intubating, you get this next reading now. You finish, you say you're a champion. What will you do next? 1, 2, 3, or 4. Those that say 2, raise your hand. Those that say 3, raise your hand. Those that did not raise your hand anyway, raise your hand. All right, so defibrillate. VFib or pulseless VTAC, defibrillate as soon as possible increases chances of survival. Again, preparation. BLS is still paramount. A lot of patients will come back at BLS. But you need to be able to start. While you are doing BLS, you need to be thinking, what are the causes? You need to think about crisis resource management. I would say crisis resource management has 4 components. What are the 4 components? Leadership, communication, preparation, team dynamics. Then crisis resource management, reading, identification and therapy, airway management. We didn't talk about airway management because that's a very big one. We need to teach airway skills, post-cardiac arrest care, and specialized interventions. And these are the things we showed you about preparation. And we said you should get the crash cards. BLS, you do your BLS. So the key slide we showed you about BLS. In summary, confirm situation, call for help, adequate compressions, airway and ventilation, defibrillation as soon as possible. And then we said the 4 principles. Another thing that I used to say, they must declare roles. So sometimes when I come in and I do the first thing I identify, you are documenting. You are doing this. So those role of documenter, CPR people, 2 or 3 people, people on the air, the person that will hold it open, the person that will bag, the person that will start calling for the other, and the person that will record any other thing should be there. And then sometimes you have an extra person, the person that will inform the relatives. It's always better to inform the relatives while you are doing CPR. Not that, sorry, you went out and they came and said the patient is dead. No. Patient has gone, we are doing this, we are doing that. It changes a lot of things. It just helps relatives to prepare. So not that they just finish, they now told them. Okay, so very important. And then, very important team debriefing we said. We said there are 2 types of rhythms, cardiac arrest and non-arrest rhythms, Abi? And then they are shockable and non-shockable. And the non-arrest rhythms are narrow and wide comes like cardia and bradycardia. These are subdivided into what? Stable and unstable. And then we decide from there what to do. For cardiac arrest, we decide whether it is shockable or not. And then every 3 to 5 minutes, add a VMO their own. For those with tachycardias, unstable, cardiovert. Whether it is wide or narrow, once they are unstable, you need to cardiovert. And when it is stable, the narrow ones, you start with vagal maneuvers and meds. If it is wide and they are stable, it's medication straight. Unlikely to be any vagal maneuver that will help in that regard. And then you keep on checking for all the causes, as well said. All right. So post-cardiac arrest algorithm is check for spontaneous